This video presents a summary of the article titled "What Can Analytics for Teamwork Proxemics Reveal About Positioning Dynamics in Clinical Simulation?" Our context is on nursing education simulations. Here, nurses students are set into teams with specific roles. They have to perform certain tasks to improve the patient's status. Nurses require some spatial abilities such as keep close proximity to patient or team members, position themselves in specific locations to accomplish specific tasks, adoption of specific spatial arrangements to enable interaction or avoid disruptions. Using interpositioning trackers or sensors, data points per second were collected. These including tag ID to identify the role, the timestamp, and the X and Y coordinates plus the body rotation. As part of the research, an interview with educators was conducted to elicit nurses' expected spatial behaviors. After the analysis, teachers' expectations were grouped in three: expected interactions between specific roles or with the patient. For example, nurses should be close to the patient during or after any deterioration, such as an allergic reaction. Second, expected social arrangements during the simulation. For instance, preparing or stopping antibiotics required two nurses working together. And finally, expected spaces where a particular nurse should position herself or himself. To give you an example, nurses are expected to be near to the patient, validating that the intubation is working properly. This is the proposed modeling approach for mapping from 1. Low-level positioning data to 3 different higher-order constructs with the purpose of addressing meaningful questions that an educator may formulate to engage with the students in dialogical feedback, emic perspective in our approach, or the insider perspective view, in our case the nurses educators, or questions that could be interesting for researchers to analyze teamwork activity in general, the ethic perspective or outsider view, in this case, for example, the CSCW researchers. So let's review the 3 proxemics used. First, the co-presence in interpersonal spaces. Using X and Y coordinates, co-presence in interpersonal spaces was modeled. Interactional spaces enable close proximity among people and mutual attention to each other, and the objects they manipulate. Classic work on proxemics outline 4 types of distances: intimate, personal, social, and public. Each type is defined according to distance in meter. Most interpersonal interactions tend to occur under 1.5 meters. We evaluate interpersonal interactions from 0 to 1.5 meters. Then we aggregate and visualize nurses' proximity using social network analysis. Notes in the graphs represent the different roles, and connections are the percentage of times that nurses spend in close proximity. That way, teachers can know, for example, if nurses were close to the team leader during a particular phase, using a full social network that has validated presence of nurses in the team leader interpersonal space. Or if nurses were around the patient during the simulation. For instance, in the ego network, we can appreciate that nurse 2 spent 21% of his or her time with the patient. The second construct was used to model socio-spatial spaces, or phase informations. That refers to the ways people cluster so that they can have direct and equal access to one another. For example, in circular formations, in a side-by-side formation, in a face-to-face formation, or in an L formation. Using X and Y and body rotation, we identify formations to understand how teams coordinate and communicate to achieve tasks, including collaboration. Then we use the graph codes for F formation or GCFF method to automatically model this construct based on the positioning data. We visualize the outcomes from this GCFF algorithm of 4 teams while stopping the IV fluid during phase 4 to validate how teams physically arrange while stopping the IV antibiotic. Team 8 didn't exhibit any specific formation as nurses were at different sides of the bed while nurse 2 stopped the IV antibiotic. Although this doesn't necessarily suggest an ineffective teamwork behavior, it can signal that one nurse was probably stopping the IV by himself, which for procedures with the patient medication may require 2 nurses. In contrast, the visual outcomes of Team 9, 10, and 11 show particular F formations during the IV fluid stopping task, side by side in the case of Team 9, and L shapes for the case of Team 10 and 11. For the last construct, the spaces of interest for this simulation were detected and classified into fixed, semi-fixed, and dynamic spaces. Then, the modeling revealed the presence or absence of nurses on those spaces of interest. The meaningful spaces for these simulations are presented in the figure, such as the patient mannequin, near to the patient, close to the IV device, elsewhere in the classroom, and so on. Then, the analysis was performed using ENA representations. ENA is a novel method used for identifying connections among elements in coded data and for representing such connections through dynamic network models. Based on Edward Hall's theory of proxemics, spaces of interest were classified in 3 types. Fixed, which have their shape and size determined by the presence of objects that cannot easily be moved, such walls. The medicine room is one example, and nurses are expected to be at the medicine room retrieving the antibiotic and the IV equipment. Then semi-fixed, which are established by movable features in the environment, such tables, clinical trolleys, that only remain unmovable and unrearranged during people's interactions. This is one example, being close to the IV device. After noticing the patient is having an allergic reaction, nurses are expected to be close to the IV device to stop it. And finally, the dynamic spaces, which are formed solely by spacing and orientation of individuals as they interact with each other. In our case, asking for help is one dynamic space where nurses are spending time elsewhere in the classroom and close to the doctor. This figure shows the epistemic network of Team 7 transitioning between the bed footer, here on top, and the patient mannequin most of the time. Moreover, this team received some help, as we can see in the visual, from the teacher. According to the educators, this can indicate that the team had to receive a kind of additional support or instruction to address the simulation. In contrast, although members of Team 9 also remain very close to the patient, mannequin, and the bed footer, here in the slide, they occupied other meaningful spaces during the simulation, such elsewhere in the classroom or close to the IV device. And this can be an indicative of patient-centered care, and is an indication, as we can see, that this team can be more independent. As part of the discussion, from a teaching and learning perspective, the uses of evidence conveyed via appropriate visualization is critical for providing feedback to students. Through data vignettes presented above, we have illustrated the potential of automatically generate evidence about positioning strategies to address authentic questions that educators have when monitoring, assessing, and reflecting on nursing team simulations. To modeling proxemic constructs could also be used to meaningfully analyze teamwork within other contexts, such co-teaching, team sports, training settings, or firefighting. Finally, there are some limitations to consider. Additional empirical evaluation is needed, the modeling techniques used are context and task dependent, and some abnormalities in data as rotation need to be attended. So, thanks for your attention. We encourage everyone to read the whole paper for additional details. Thank you.